All right. Thank you, everybody, for being here out there, I guess. And as you probably hear from everybody, we're going to be going through a lot in a relatively short amount of time. I could probably talk about psychiatry all day. But hang in there with me, and hopefully this is a good refresher. I have nothing to disclose. And so this is really the blueprint content from the website for physician assistants, and this is the order that we're going to go through things. But first, we're going to start with a few questions. So the first question is about a 35-year-old female who comes into your clinic for a follow-up of depression and anxiety. She currently gets extended release venlafaxine, which is Effexor. Sometimes, though, as you probably run into with patients of all backgrounds, she doesn't take her medications consistently. And we see this all the time in psychiatry, as you probably do in a lot of other areas. When this happens, though, she feels more anxious, irritable, fatigued. She feels shock-like sensations going through her head. Patients call these brain zaps. In addition to these symptoms, which of the following signs or symptoms would also be consistent with serotonin discontinuation syndrome? And you guys can go ahead and vote, and then we will reveal the right answer. Okay. All right. So the actual answer is B, flu-like symptoms. And I can see why C was thought about. Increased sweating and muscle rigidity is something that you see with serotonin toxicity, serotonin syndrome instead of serotonin discontinuation syndrome. So I apologize if that was a little misleading. The next question, though, we have a 26-year-old female. She's on the inpatient psychiatric unit for depression and suicidal thoughts. She wants to start an antidepressant. She wants to get help. However, when you talk to her, she admits to binging and purging as well, up to 3 times a day. These are her vital signs, overall looking pretty unremarkable. Her BMI is 26.6. With this knowledge, out of the following medications, which medication would you want to avoid prescribing? And so D, yes, D is the correct answer. Bupropion lowers your seizure threshold, as does potential electrolyte abnormalities with vomiting. So that is one that we try to avoid with really anybody that has an eating disorder. Next, we have a 24-year-old who is brought into the ED by his roommate because he is behaving bizarrely for the past 2 months. He's been talking to himself, frequently straying from topic and conversation. He's more withdrawn. He's not taking care of himself. He lost his job. His roommate ultimately brought him in because he woke him up in the middle of the night saying that someone was putting cameras in his room, the government is monitoring him. Based on this current presentation, what do you feel is the most likely diagnosis, knowing that this has been going on for 2 months? All right. All right, kind of a mix. The correct answer is C, and the key here is really the time duration of 2 months, and we'll talk a little bit about that later, and how a time duration is really how we in psychiatry help tease out where things are in terms of like a schizophrenia spectrum, and other illnesses like depression and things like that. So definitely displaying psychotic symptoms that could fit with any of these illnesses, but the time duration is really what's important here. Next, we have a 21-year-old. She comes into the emergency department after she texts a friend that she's suicidal. She just broke up with her significant other. She's feeling pretty abandoned, distressed, even though this relationship was really chaotic and intense. She also has pretty intense emotions. They are kind of like a roller coaster. They fluctuate frequently, even throughout a single day. Usually, these fluctuations are due to stress and argument, things like that. Sometimes she takes part in risk-taking behaviors, substance use, increased spending, sexual behavior. You also notice that she has several superficial cuts and well-healed scars on her forearms, and she also has a history of multiple suicide attempts. Based on this information, and we don't necessarily make this diagnosis in the emergency department. We usually wait until they get to the inpatient unit, but regardless, based on what we have for information, what do you think the diagnosis is? And so, doesn't surprise me at all that borderline personality disorder and bipolar disorder are neck and neck, because they appear very similar. The correct answer, though, is C, borderline personality disorder. And we'll talk about kind of the differences in terms of how you tease those things out. And I'm happy to answer questions about that too, because like I said, they often get misdiagnosed for the other. Some important things are that her emotions fluctuate within hours or within the same day. Whereas with bipolar disorder, it's usually a persistent mood elevation instead of things going up and down and this way and that way all within the same day. And then we have a 57-year-old male. He's on the inpatient psychiatric unit. He has paranoid schizophrenia. He unfortunately went off his medications, but had done well on them previously. Prior to restarting any antipsychotics, what laboratory values should be obtained as screening and monitoring for medical comorbidities that are sometimes seen with patients who have schizophrenia? So probably another tricky question, because quite honestly, we would check all of these things. With psychotic illnesses, though, the thing we'd want to keep an eye out for most is B, their fasting glucose or hemoglobin A1C and a lipid panel. And this is because a lot of antipsychotics, particularly our second generations like olanzapine, are at a pretty significant risk of causing metabolic syndrome, especially when they're used long term. So, but quite honestly, like I said, we check them all. So with those questions behind us, we'll jump right in.